Good evening, everyone, and welcome to another Cobalt School of Clinical Imaging event. We have Dr. Udeshi with us this evening talking through some cases, hopefully a big mixed bag this evening for you. Um, we're recording the session. We should be able to make it available online after the event as well. Um, if you have messages, I'll put a chat up in just a moment. Please do questions or anything, put them in the chat, and I'll pick a moment to interject, and we'll make sure that they all get answered. And I'm sure there'll be time for questions and answers at the end of the session anyway. So without further ado, I'm going to hand over to Dr. Udeshi.
Excellent. Thank you very much, Charlotte, and thank you for everyone attending for signing up and giving up an hour of your evening. I'm going to just show you a few different cases, and then after each case, there'll be a little discussion with background and what we're background knowledge, etc. So I've got 6 or 7 cases for discussion. Depending on how we do for time. Um, Starting off with some shoulder cases, then I've got a knee case, some lumbar spine, and I've got a hindfoot MRI at the end. We'll keep some time for questions and answers, and Charlotte will tell you about how to give feedback, but please do give feedback. I need it for my appraisal, and also it means that we know what you want and we can change things next time if necessary. And as Charlotte's already said, please feel free to put any questions as we're going along into the chat, and then Charlotte will interject and get me to answer them when there's a moment. Um, so, moving on to the first case then. So, what do you think is going on here? Um, you've got a shoulder MRI, that's your clue. And what you see on the images. Any abnormalities that you can see? Put quick answers in the chat. Hopefully I'll see them. I'm trying to just get the chat box out of the way.
They're having a long think. There's nothing in the chat at the moment.
Bone defect in head of humerus. Uh, Wonder where you're looking. Bone defect. Are you looking back here? That's that's the intertubercular groove, and the little oval dark area is the long head of biceps tendon. Um, where else could you be looking? I'm not quite sure. There isn't a bone defect there. Anything else? Go on, have a go. Okay, so I'll look at some anatomy, point some anatomy out for you then. So here's the bony glenoid. The little gray rim on top of it is the hyaline cartilage within the glenoid. Obviously, here's the humeral head and the metaphysis. Supraspinatus muscle is here, and it forms the tendon, which attaches here on the greater humeral tuberosity. This is the acromion. This is the clavicle. We haven't quite shown the actual acromioclavicular joint, I don't think, on that slice. So that's a coronal image slice. This is axial, which shows again the glenohumeral joint. At the front will be subscapularis tendon, biceps tendon in the groove, and at the back will be the infraspinatus tendon here. Tendon should be dark, uniformly dark on all MR image sequences. And then here's a sagittal, which is probably done through about here. You're seeing a little bit of the deltoid muscle on top, this one here. This is the supraspinatus tendon here, just attaching onto the humerus. So, any other looks like pages effect? What does that mean? What's pages effect? You've got me there. Okay, let me tell you what is going on then. So here's the supraspinatus tendon. As I said, it should be uniformly dark, but you can see a little bit of bright signal here, and actually underneath that in the bone, you can see a little bit of edema. And then when you go to the sagittal, we've got the same bright signal there, and on the axial as well. Let me just show you. There we go. Here's the arrows telling you where the high signal is. So there's focal high signal in the tendon. It's in the footprint, so it's where it attaches to the bone, and it's starting on the undersurface or the articular surface and then heading out towards the bursal surface. It's not full thickness. There's no increased fluid within the subacromial bursa, so that again confirms it's not full thickness. So that's called a rim rent tear. It's an intra-substance tear. It's actually in the substance of the tendon itself. Um, so so it's a partial thickness tear. It involves, in this particular case, it involves the articular surface of the footprint of the tendon attachment. Um, it can extend along the tendon fibers, causing delamination. Who gets it? Overhead athletes, younger people, and smokers, apparently. And what's it due to? It's due to abnormal shear stresses on the tendon and extrinsic impingement. In other words, impingement usually by the acromion, so it's subacromial impingement. And why does it occur? Because there's micro trauma and repetitive contact with the posterior superior glenoid rim as well. And then surgical treatment is indicated if the patient is symptomatic or if conservative treatment fails, or it's large enough so that more than 50% of the tendon thickness is involved. So it's not strictly speaking a tear that the surgeon can see on arthroscopy. He won't see that because when he puts his arthroscope into the subacromial space, the tendon surface is intact. And then if he puts his scope into the joint itself and looks upwards at the undersurface of the tendon, then he can't see where the tear is because that's where it's actually attaching to the bone. So it's actually invisible to the surgeon on arthroscopy. And that's why MRI is so important to make this diagnosis. Symptoms will be like any other rotator cuff tendon tear. Okay, so trying to move on. There we go. So here's case number 2. So it's another shoulder. What do we see here? Any ideas? Oh, that was Paget's. Okay. Fatty infiltration in the supra. Ah, okay. That's a thought. But if we look at this image, it's a proton density image. Look at the color of the fat. That abnormality there is that abnormality and is that abnormality. So it's not the same signal as fat. It's brighter than fat. Um, very bright. So this is a fat suppressed image sequence because the fat is dark. So the only thing that can be bright on a fat suppressed image sequence is what? Where are all the radiographers? Come on, radiographers, we need an answer to that question. What's okay, so now that's a good thought. Subacromial bursitis. So in other words, you're saying fluid, aren't you? Water, yes. So, but it seems very loculated. Look, it's sitting in a little locule. It's actually hugging the muscle. In fact, you could even say it's possibly in the muscle tendon sheath. Oh, sorry, muscle sheath. So it's not subacromial. It's not spreading out down here in the subacromial bursa and then down underneath the deltoid, is it? It's actually loculated, so it's more like a cyst than free fluid. So how do you get a cyst on the supraspinatus muscle? What causes that? Anybody? Why do we get a cyst there? So here's a coronal sequence. You see the fluid there. Here's the sagittal. You see it there. It's on the surface of supraspinatus. And here's an axial. Now, where do you see the fluid on this one? You see it there, yes. Anywhere else? Where do we see that fluid? Is it just there, or can you see abnormal fluid anywhere else in that image on the right? Okay, rotator cuff. Okay, look, here's the tendon running down the middle of the supraspinatus muscle. Here's a bit of the tendon because from the muscle fibers, they join in a multipennate structure, the tendon, which then coalesces to form the tendon, which you then see outside the muscle. So here the tendon is beginning to form actually in the muscle belly, and there's high signal running along it. So this fluid has tracked along the tendon and is collected in a cyst. So what this is a trying to get this. It's a longitudinal split tear of the supraspinatus tendon. And in fact, if I'm not mistaken, this these images are the same patient as this one. No, it's a left and right is different. Okay, it was a very similar patient. Um, so this patient here that we're now looking at, actually, I think also had a rim rent tear. So what has happened is that the tear started in the footprint of the tendon and then has extended along the tendon into the muscle and the fluid has collected in a little cyst or locule. You don't have to have a rim rent tear. You can get these by delamination of the tendon alone. Um, so it's led to longitudinal split and separation of tendon fibers. It's typically observed in the rotator cuff, delamination tear that is, but it can occur in other tendons. You can certainly see it in the tendons around the ankle, and it can happen in the long head of biceps tendon as well. Um, so if you see any cystic collection in the tendon or in the rotator cuff muscle, you should think of a longitudinal split of the tendon itself. Okay, now this is the same condition, but it's in a different patient and in a different muscle. So here on the sagittal image, here's supraspinatus, that's where we've seen it before. This is infraspinatus muscle here. This is subscapularis and teres minor here. So look at the axial. You've got a little bit of signal here, and then it's actually running alongside the tendon into the muscle. And you see it here where it's looking bigger. And then on the coronal image, you can see it here running just underneath the tendon. So that's another delamination injury, but it's in the infraspinatus muscle. It looks just like a cyst. You don't really realize that it's a tendon tear, but it is. Okay, so that brings us to case number 3. So, what do you think now? You've had a bit of practice at looking at shoulders. So what we've got here is 3 fat suppressed images, these 3 on the right, and this is a proton density image on the left. Anyone spot anything? Do you see on these images? That first image is actually very similar to case number 1. So you see some high signal here in the supraspinatus footprint. So there's another rim rent tear, in fact, here. Okay, so fluid signal in the supraspinatus tendon footprint. But then these three are fat suppressed images. So we've got rid of all the bright signal that you can see here on the left-hand image in the fat. So the subcutaneous fat becomes dark, but the bone marrow, which also consists of a lot of fat, also becomes dark. You see there and there? So the only thing that's allowed to be bright on these fat suppressed images is fluid. So it's edema or water. Anything that's looking bright is fluid. So where do you see the edema? Where do you see the fluid? That's the question. That's telling you what's going on here. Any answers? Ah, adhesive capsulitis. Yes. Okay. It looks like it was too easy. Um, okay, so what do we got here? Look, we've got edema of the subcoracoid fat. This is the coracoid process. There should be just fat in here. It's probably that bit of fat. And it's now very bright. It should be dark, like the subcutaneous fat up here, but look how bright it is. So there's edema there. And then if you look at so the joint, so that's the subcoracoid fat again, and then around the glenoid and the humeral head here, this bright sort of rim, this quite thick bright rim, that's got to be the joint capsule. So that's edematous and it's thickened. And then here again, that's the joint capsule up here, that's bright. And here, that's the joint capsule that's bright. So the joint capsule is thickened and edematous. And then on this first image, if you look down here at the axillary recess, that's the inferior glenohumeral ligament. And that's thickened. That's thicker than it should be. So all of that is telling us this is an adhesive capsulitis or a frozen shoulder. Now, um, I'm not trying to say that you should do an MRI scan if you suspect a frozen shoulder. But as we get better with MRI, we now do see specific signs that may help us make the diagnosis. So in the early stages of adhesive capsulitis or any of the shoulder syndromes, symptoms may not be quite typical, and it can be difficult to work out what's going on. And in that sort of case, you might actually make the diagnosis with MRI. So that's my little artistic uh, art picture of a frozen shoulder. Um, and this particular patient had both a rim rent tear and a frozen shoulder. So it's not a primary adhesive capsulitis, it's probably a secondary. So there's been, if you like, an injury and then followed with adhesive capsulitis. And these are the findings that I've already told you about. There was a thickened coracohumeral ligament, there's soft tissue thickening and edema in the rotator interval. That means um, continuous with the subcoracoid fat and between the supraspinatus muscle and tendon and the subscapularis muscle and tendon. The thickened inferior glenohumeral ligament, that's the inferior recess, and then thickened soft tissue also around the biceps anchor, which I think is this bit here. Okay, so that's a frozen shoulder.
Umesh,
Yes.
um, Tim Holt has asked, is MRI always useful for frozen shoulder?
Is MRI always useful? Not necessarily. Um, I mean, it should be a clinical diagnosis most of the time. But if there are confusing signs and symptoms, then you may actually do the MRI to exclude other causes. I think that's what the place of MRI is, that you trying to exclude the rotator cuff tear or any other shoulder problem. Um, and the adhesive capsulitis, if you do see the signs of it, they're sort of an added bonus, really, because it's also a diagnosis by exclusion. So once you've excluded everything else and they've got very limited range of movement and very painful shoulder, then there's your diagnosis. So no, you don't really do imaging to make the diagnosis. You do it to exclude other conditions. Okay, let's move on. Okay, we're on to the knee MRI. What do you think is going on here? So we've got a sagittal, these are all fat suppressed images, proton density fat suppressed. There's a sagittal image here on the left, coronal in the middle, and an axial through the abnormality on the right-hand side. So what do you think is not looking normal on those images? Quads tendon. That's the quads tendon. It's okay. There's a little bit of brightness in front of it, so that would be a prepatellar bursa, a little bit of a prepatellar bursa there, some edema there in the subcutaneous fat. Anything else? Let's see what we got. ACL, high signal at tibial attack. Okay, well this is abnormal, isn't it? So here's the ACL, anterior cruciate ligament, and what's this thing? There's something sort of protruding from it, pointing forwards. And here's the ACL on the coronal image. And it should be a band. It should be a straight, a linear sort of thing. But you've got something little round here, which I think is probably the tip of that. And then the rest of the ACL underneath would be there. And then look at it on the axial. Now, the axial's been done through that abnormality there. And look at it. It's this great blob here. The ACL can't look like that. It has to be a band. So what is that? I mean, the ACL is looking gray. It should be looking black. So ligaments and tendons should be black on all sequences. That's not black, that's gray. And it's too thick. That's not a normal thickness of the ACL. So it's definitely an ACL problem. But what is it? ACL, PCL, yeah. We don't see much of the meniscus. We do see in the coronals. I don't see a tear. I think they're okay, at least on that one slice. So why is the ACL looking so odd shape? Who can tell me? Okay, well, the clue is on this picture. So this fella is Cyclops. He's got one eye. And what's Cyclops got to do with this? So if we take this left-hand image, when the surgeon does an arthroscopy, he puts his scope in here. He goes into here or into here, and it's pointing straight at this abnormality. So he sees this abnormality looking at him. So he sees something pointing straight at him, and then normally shouldn't be anything there because the ACL will be running away from him normally. So that looks like an eye looking at him. And so that's called a Cyclops lesion. So it's an ACL tear, but it's a partial tear. So it's not a complete tear, it hasn't gone all the way through. A part of the ACL has torn and then it's folded over and is pointing forwards. So normally that bit should be going upwards along with the rest of the ACL. But this is a partial ACL tear. And it's a Cyclops lesion. Now, it's most commonly seen after an ACL reconstruction where you get a fibrous mass in that spot in the anterior intercondylar notch, which then impedes knee extension. You can't straighten your knee fully because that fibrous mass is sitting in the way, and that's a post-operative fibrosis. But it can occur after an ACL tear without reconstruction, also like the example I've just shown you. And you may get a history of reduced knee extension following an ACL injury or reconstruction. There'll be anterior knee pain. There may be altered gait because they're not able to extend fully. Um, if it's post-op, it's called Cyclops syndrome. And it, it's telling us that surgical treatment is indicated either to repair or reconstruct the ACL if it's a de novo Cyclops, or if it's fibrosis after reconstruction, then they need to go in and resect the fibrous mass. So either way, uh, surgical treatment is indicated for that condition. So just a little bit about grading ACL tears. Um, so this is a very simple grading system. There are more complex systems described, but very simple. So grade 1 means the ACL has been strained, so sprain. So it's thickened and there'll be increased signal, but there'll be no discontinuity. And there may or may not be a little bit of laxity. In other words, tibial instability in the lateral compartment, or clinically you'd call that a draw sign. Um, so grade 1 just means thickening and increased signal on the MRI. Grade 2 is a partial tear. So it hasn't gone all the way through, but there is a partial tear. Look, here it's sagging. It's not a normal morphology. It's not a nice straight line. It's a little bit gray. Um, it doesn't look normal at all, and there will most likely be tibial instability in the lateral compartment. And grade 3 is a complete tear. Now, this particular image down here shows a chronic complete tear. So the ACL has just disappeared from view. It's not there. Why is it not there? Because it's scarred. It was torn completely, and then it's scarred and stuck down somewhere where you can't see it anymore. It's not normal in the slightest. So it can be that it just completely disappears in a chronic ACL tear. And obviously that'll be a deficient knee. There'll be a lot of tibial instability. And just to show you what a normal might look like. So you should see a nice straight line. You should see two or three little thin dark stripes or dark bands going through the middle like that. Um, the knee is in the knee coil when we're doing the MRI, there's a little cushion, there's a little pad just underneath the top of the calf here, which means that the knee is ever so slightly flexed, something like 20 to 30 degrees. And in that slight flexion, the ACL should be taut in a nice straight line. So this is the one I showed you. This is this case. So you see how abnormal that ACL looks compared to this one. It should look like this one. Okay. Any questions, any comments on that one? Ah, Mary got Cyclops. Thank you. Any comments, any questions? Okay, let's move on then. Okay, the first of our lumbar spine scans. So I've got two sagittal slices here. So I think this one's a T2, and this one's a stir. So this is a fat suppressed. This is a T2. Um, you can see all the lumbar vertebrae. You can see the discs here. Sacrum is down here. We're just about beginning to see the lateral exit foramina here. And one of those dots, the thicker dot, will be the exiting uh, nerve. There'll be one or two little smaller dots, sometimes looking linear. Those are the vessels alongside, because it's a neurovascular bundle, so those are the vessels alongside the nerve that's exiting there. And I'm sure you all know, but just by the way, if we look at, say this vertebra here, that's L4. So if the pedicle is here and the neural foramen is underneath it, this nerve coming out underneath the L4 pedicle, which nerve would that be? Anyone? Which nerve would that be underneath the L4 pedicle coming out here in this exit foramen? So that would be the L4 nerve, okay? So it's named from the pedicle that it's going under. So that's L5, that's L3, L2, L1, etc. Um, Now then, so here's an axial image through probably about that sort of level. And you see the theca here, you see the various little nerves in the theca. So that's the chordae equina, all those little black dots. That's the chordae equina, horse's tail. And that's the nerve, I don't, which level would that be? That would be maybe 2, 3, or 3, 4. So that would be, if this is 3, 4, then that would be L3 nerves coming out of the exit foramina. And these are the facet joints at the back. So the theca is almost a round shape. It's not totally round. So that's pretty normalish looking fecal sac. In front of the spine, the slightly smaller rounded structure is the aorta, and the flatter looking, probably slightly bigger, is the inferior vena cava. And that's probably aorta, and that's aorta, because you've got branches here. So that's celiac artery. This is superior mesenteric artery here. Can you see any abnormality on this, anyone? Not an easy one. Maybe I'm not quite. Let's go down here. Okay. Okay, so the clue is I'm not asking you to look at the lumbar spine. I'm actually asking you to look at the structures around the lumbar spine because you do need to look at those carefully too. Um, so here's the aorta. What color should the contents of the aorta be on an MRI scan? On a single slice of an MRI scan, what color should we see inside the aorta? Or for that matter, IVC, in fact. Radiographers, where are you? Aorta. Other way around. It should be dark, shouldn't it? Why should it be dark? Because it's flow void, isn't it? What's flow void? Okay, so the MRI works by repeatedly by sending a radio frequency wave into the body and then waiting for the echo. So while you're doing this slice, there's a radio frequency wave gone into all these structures, including the aorta. And then you wait for the echo coming back. You wait for the reflection coming back of that radio frequency, and you use that reflection to make the image. Now, what does the aorta contain? It contains flowing blood. So if the blood sitting here in this spot gets a radio frequency bombardment on it, it then has already moved to the next spot down here before it can send its reply back, before it can send its echo back. So from this spot here, where you sent the first radio frequency pulse, you're basically not getting any reply of the same frequency because that bit of blood's moved on to the next spot, next slice, by the time you get your reply. So in any structure where you've got movement, you're not going to get uh, a reflection back. So what this is, why is it dark? It's dark because there's no appropriate reflections. That's so we call that flow void. It's due to flowing blood. So it's disappearing before it can reply to our radio frequency pulse. So look here, this is all black. This is mostly black, not very nice and clean, but it's black. But what's going on here? It's a little bit narrower, this aorta, and it's bright. So you can't have bright signal in a normal aorta. It's a little bit gray here. And look on this axial. You've got a rim of bright signal, and then there's something else rounded and gray here. It's not black. So what that is it's not flowing blood, basically. So that is an aortic occlusion, either through clot or atheroma or whatever. But there's a section here of the aorta which is occluded. So just to show you what it should look like, it should look nice and dark and even all the way through on this right, as you have got on this right-hand slide. But over here, it isn't, and that's an aortic occlusion. So you do need to look at structures around what you're being asked to look at just to make sure there's nothing else going on. And I've got another aorta, which is abnormal as an example of another pathology. What do you think this is? This is a bit easier. What are we looking at here? Ah, there we go. Quick answer from Catherine. Yes, abdominal aortic aneurysm. Look how wide this is. Look on the transverse image. It's huge. It's probably 4 or 5 centimeters, maybe even 6 in places. So it's too wide. And then in the middle, look, now you've got flow void in the middle. So there's flowing blood here, but there's no flowing blood out here. So because that's clot. Because aortic aneurysms very often will clot around the periphery. Why do they do that? Because it's chaotic blood flow in there. It's like a washing machine. Um, if you were to, like on the front loading washing machines, if you were to lift up the lid and look down, you'd see all this chaotic flow. And on color Doppler, that's what you sometimes see, particularly in an abnormal aorta. So because it's chaotic flow, it's not flowing away normally, it clots around the outside. So that, and then it's aneurysmal, it's fusiform here shape. It's a more normal shape up above, where you've got the superior mesenteric coming off and the celiac artery coming off. So it's distal to the superior mesenteric. Now, what else is going on? There's this rim of bright signal behind the aorta and in front of the spine. So this is not flowing blood. It's not flow void. This is static fluid. You can't have static fluid sitting between aorta and spine. That doesn't make any sense. What is that? And then you've got bone bruising. This is a stir image. So all the marrow is dark, except here next to this area of fluid in the aortic aneurysm. So there's something going on here in the bone on this stir image right next to the aneurysm. So what this is a small contained leak. It hasn't exploded, hasn't burst open, but there has been a little bit of leak of blood here at the back. And this marrow edema, it's either a pressure effect from the aneurysm or it could be something else. And what actually this patient had was a mycotic aneurysm. In other words, the aorta was infected. So that's called a mycotic aneurysm. And the reason there was edema here, because it's probably, it's the infection in this aneurysm that's beginning to spread now into the bone. Um, so that was, I mean, mycotic aneurysms are very fragile. If the surgeon isn't careful about how he goes in to treat this, it could just fall apart in his fingers. So they're very difficult to treat. And if he knew before he went in there, he'd probably want to try, first of all, treating with antibiotics and getting rid of the infection before he actually tried to treat this aneurysm. So it's very important that you tell the surgeon from the imaging if there are any clues that it's not straightforward atherosclerotic. Um, and how do we know an aneurysm is atherosclerotic? Um, it's because in an atheromatous artery, there will be calcification in the wall. And when you get an aneurysm, you expect to see the calcification out in the periphery, in the wall of the aneurysm. You don't expect to see it anywhere else. Now, it's quite possible in this sort of patient that calcification would be along here somewhere, right next to the lumen, because all this stuff outside is clot or inflammatory tissue. So this aneurysm may not actually, the aortic wall may not be here, may not be out here. It may actually be in here. And if you did an ultrasound or a CT, you might see the calcifications actually in the middle of the aneurysm rather than right out along the wall. And that would be a clue that it's not a simple arthromatous aortic aneurysm. Okay, any questions on that last one? Uh, yeah, dissecting, yeah, it was certainly leaking, yeah. Okay, we're on to the next case. Um, so the question I want to ask you here, there's one or two things I'm sure you can all see, but how old do you think this patient is? That's what I want to ask you. Look at the pictures and give me a guess. How old do you think this patient is? What do we got? 40, 30, someone's saying. Okay. 30-year-old? Okay. Have we got any degenerative changes on these scans? Yeah? Yeah, we've got degenerative changes. Um, so who gets degenerative changes? 30-year-olds? Would you say 30-year-olds get degenerative changes in there? These are the discs, aren't they? Look, these bottom two discs are dark compared to all the ones above. That's a normal disc signal. There should be bright signal on the T2 and the stir images, but these bottom two are dark, so they're already dehydrated. And maybe you can persuade yourself that disc height is a bit less than that one. It should be more. So it's beginning to lose some height as well. So that's degenerative change, isn't it? Yeah, degenerative disc disease. Ah, sorry, Catherine, to hear that. Um, okay, so actually, this patient was 24. And I saw this patient today, in fact. It's hot off the press. And okay, so the disc is dark. So there are two degenerate discs at 24. Um, what does everyone think? Unusual or not? Who's gonna... Do we think this is unusual in a 24-year-old? Yeah, Carlos says yes. Anyone say no? No, everyone's saying yes. Okay, okay. So, now, actually, let's just leave it at degenerate disc for a minute, and then we'll come back to what else it shows. Acute disc protrusion. Okay, I didn't want you to see that. Too late. Now, so here's a study. It was actually published in 2015. It was over 3,000. It was something like 3,100 patients who had no back symptoms, had never had back symptoms. How do you find 3,000 patients without back symptoms? Anyway, they found them. They must have been volunteers, I think. And they scanned them, and this is what they found. So the patients ranged from 20 to 80, but nobody had back symptoms. So disc degeneration in 37% of 20-year-olds, or I think this must mean in that decade, in the 20s, had disc degeneration. And it goes up, obviously, with age. 30-year-olds, 52%, 40-year-olds, 68%, 50-year-olds, 80%. And as we get into 60 and 70 and 80, well, if it's happening that often, isn't it? It's just normal, isn't it? And then disc signal loss, so that's just a little bit less in terms of percentages. Disc height loss, a little bit less than actual, because these two together make disc degeneration, don't they? And then bulges. So bulge means the annulus fibrosis is still intact. So again, we've got 30%, 40%, a lot. Even in the younger age group, we've got a lot of the asymptomatic individuals have got these changes. Disc protrusion. 20-year-olds or 20s, 29% have disc protrusion. Annular fissure, 19%. Facet degeneration, much less, 4%. And spondylolisthesis, again, much less, 3%. But what this slide is telling you is that degenerative changes in the lumbar spine are really very common even from the age of 20. So when you see a patient with these changes, how are you going to know whether it's relevant or not, whether it's the cause of their pain? Is it the pain generator or isn't it? When you see all these things, should you pay attention? Should you not pay attention? How do you make head sense of it all? Okay, so there's a more recent study uh, from last year. I think these were about 240 patients, participants, and what they did was they took these are patients with symptoms and they split them into two groups and um, they they had already given them all a questionnaire asking them what their symptoms were. So patient reported symptom questionnaire um, or symptom questionnaire um, and the radiologist reporting the scan, half of them saw the questionnaire and half of them didn't. So in other words, half knew the history and half didn't. So they're trying to distinguish pain generators from incidental findings because we can see that from the previous slide, incidental findings are very common. When they had the questionnaire and the history available, they were asked to decide what was the cause of the pain. The radiologist correlated almost perfectly with the specialist spine referrer. So is a spinal surgeon or a musculoskeletal specialist who dealt with spines all the time and who had made up his mind what he thought the patient had. And when he knew the history in detail, the radiologist was almost always correct in getting the same answer. But when, and also, those who knew the history, they were more certain that they were getting the right diagnosis. This certainty was much greater. Now, you might say, well, that's common sense, isn't it? But actually, sometimes we get very poor history, and most of us don't, you know, insist on a full and complete history. We don't send the request back saying, not good enough, there's only 2 lines, I don't know what you're talking about. But maybe we should. Um, so, uh, in asymptomatic individuals, disc degenerative changes are common. And these degenerative changes may not be symptomatic or responsible for the patient's concerns. So it's important to get a good history from the referrer or the patient and then correlate what we're seeing to the patient that should be not related, patient reported symptoms to ascertain the significance. Um, and so that last paper I was um, telling you about, this was the editorial that went in the Radiology Journal with it. And the editorial um, points out that MRI is very sensitive for finding pain generators, but it's not very specific. On its own, it won't tell you which one is the most important finding. So an accurate and focused history and examination can provide clarity as to which will be the most important. Um, So in the report, the radiologist should then emphasize the pathology that corroborates the given history. If there are 5 findings, you don't give all of them equal weight. You should report canal narrowing. You should report neural foraminal narrowing. We should also report facet joint arthropathy or synovitis. Quite often that information is missing from a report. And we should also report the end plate, vertebral end plate marrow signal changes, modic type 1 and 2. So modic type 1 is when you get edema, so bright signal on T2 and stir and low signal on T1. That's the earliest stage, and so degenerative end plate changes start with edema. Modic type 2 is when that edematous area, the fat in it, um, the marrow becomes especially fatty. after the edema. So that's modic types. The reason you want to mention those is because they can be painful. And then annular fissures can be painful. Um, and obviously discs that contact nerves are important because you may get symptoms from nerve contact. It doesn't have to be compression. And in the acute phase, even minimal nerve contact may give you what you think, what symptoms of radiculitis. So these are all important findings given the correct history. Um, okay, so sorry to bore you again if you've been on my talks, but that's why I like to do the one-stop MRI and report clinic, because although there's a professional referrer who sends the patient along with a referral form, I see the patient prior to the scan and I just clarify, just make sure I understood the history. I can tailor the scan to answer the question that I think is being asked. After the scan, I report the exam and I see the patient before they leave, explain the findings, give them a printed copy of the report. We don't charge any more for that service than a standard report that you might get in 5 days. So the reason for doing that is um, answered by the papers I've just described, that the history is very important. If you get a good history, you have a greater chance of finding the right answer. Any questions on comment? It's still it's probably obvious, I guess. Uh, yeah, obviously we need to know that we don't take the radiology on its own. We have to correlate with the symptoms, and that's what Joanna's saying here. Yeah, I agree with that. Um, okay, so this is the last case, and we're nearly time up, but and I want to give you some time for uh, questions and answers, but I'll just show you this last one then. So obviously this is an ankle or hindfoot MR sagittal image slice, and the person with the arrows has made it easier for you. That's pointing to the abnormality. So this is a stir image or a proton density fat suppressed image. So fat has signal is suppressed, made dark. So subcutaneous fat here is dark. Bone marrow fat is dark. But look here, in the talus, inferior talus, there's edema. And in the calcaneus, this is the angle of Gisane, there's edema. So there's edema on both sides of this articulation. It's not a joint, but um, there's edema on both sides. So what's the cause? Why have we got edema there? That's a funny place. Impingement and bone bruising. Okay, Catherine. Absolutely right. Yeah. So what have we got? We got a patient with a valgus hindfoot. With a valgus hindfoot, there's been impingement of the talus on the calcaneus with marrow edema. So that may be the site of the patient's symptoms. That may be what's hurting, even though actually the underlying issue is this valgus um, hindfoot. So it should look like that with the calcaneus only at something like 6 degrees to the long axis of the tibia. Here it's more like 22 degrees, which I think, whoops, these are the normal and abnormal appearances. So it's impingement, external impingement, extra articular impingement of the talus on the calcaneus. That's what was shown here, and that's sometimes not always the most obvious cause of the hindfoot pain, but that may be one. Okay, so thank you for listening. So any questions, anything anybody would like to ask?